Well, Mr. Alam is a 65-year-old with a 2-month history of epigastric pain and weight loss. We had an OGD for him, and can we please see the images? A biopsy was done for him, and we're here to review the results. Of note, a CT scan was done, which in addition to the gastric mass, it also showed multiple liver and lung lesions suspicious of metastatic disease.
Sure, yes. The biopsy confirms a poorly differentiated adenocarcinoma of gastric origin. It is of a diffuse subtype. Immunohistochemistry for Her2 is positive +3.
Her2 positive? I thought Her2 positive tumors happen in intestinal types, not in the diffuse one.
Her2 is a proto-oncogene encoded by the ERBB2 in chromosome 17. It's also a member of the Her family. It is responsible for cell proliferation, cell survival, angiogenesis, migration, and invasion. Her2 positive status, protein overexpression, and/or gene amplification has been identified in several carcinomas, especially in breast cancer, which plays a vital role in determining prognosis and treatment plan. On the other hand, in gastric cancer, the reported level of Her2 overexpression varies widely from 7 to 27%, and the prognostic value of Her2 status remains controversial. The intestinal-type disease showed a higher rate of Her2 protein overexpression and gene amplification than the diffuse type. Furthermore, the overexpression of Her2 in stages 3 to 4 disease were significantly higher than that in stages 1 to 2. Hi, Dr. Muhammad.
Hi, how are you?
I'm well, thank you. Can I ask a question about the patient?
Of course, have a seat.
Thank you. I'll be covering your absence next week while you're away on a holiday, and I thought I'd better ask you about a few patients from the MDT. So I've got the patients list here, and the first one is Mr. Ahmed. He's a 70-year-old gentleman, previously fit and well with ECOG 0. He underwent an OGD to investigate melena, and this has picked up a mass at the JO Junction, the biopsy of which proved to be an adenocarcinoma. He had a PET scan which staged him at T4, N0, M0, and subsequent to that he had an ES which showed the mass to be abutting the diaphragm, hence it's a T4A. So I just wonder, what would you recommend in these situations? Patients with adenocarcinoma of the gastroesophageal junction are often treated in the same way as esophageal adenocarcinoma. T4A esophageal lesions, including involvement of the pericardium, pleura, diaphragm, can still be considered for surgical resection, but neoadjuvant treatments are recommended. The options are of either neoadjuvant chemoradiation, carboplatin plus paclitaxel, or cisplatin plus 5-FU, which is the preferred option as per the NCCN guidelines. The other option is to treat with neoadjuvant chemotherapy, such as cisplatin 5-FU or FLOT, which is 5-FU, oxaliplatin and docetaxel, followed by surgery, which is often followed by adjuvant chemotherapy. The next patient is Mr. Murad. He's a 55-year-old gentleman. Again, he's fit and well with no comorbidities. He was found to have a stomach adenocarcinoma that initially was staged at T1B, N0, M0, for which he underwent surgical resection. Post-operatively, the final pathology actually superstaged him to T1N1. 2 out of 15 lymph nodes were positive for cancer, and it was a D2 resection. He was seen by the surgeons and informed him of the need of adjuvant treatment. And I'm sure I'll be asked at the MDT what treatments I would suggest.
Were the margin clear?
Indeed, the margins were clear. Patients with gastric cancer who did not receive neoadjuvant chemotherapy or chemoradiation and are subsequently found to have either T3 or T4 with NAN or NET with positive nodes should receive adjuvant treatment. If less than a D2 dissection has been achieved, then the recommended adjuvant treatment would be fluoropyrimidine, either 5-FU or capecitabine, then 5-FU based chemoradiation, then fluoropyrimidine. On the other hand, chemotherapy alone is the recommended adjuvant modality in patients who have achieved D2 resection. The recommended chemotherapy treatment in this setting is the combination of capecitabine and oxaliplatin as per the classic study, which reported an improvement in disease-free survival from 59% to 64% in the chemo plus surgery versus surgery alone groups. Mr. Salim, thank you for coming to the clinic today. I know that you are very anxious to know the results of the CT scan. Well, first of all, could you tell me in your own words, what do you understand of the situation so far?
Well, indeed, I am anxious, doctor. I am actually 65, but I am extremely fit and never smoked. And I was just complaining of simple heartburn, in which the doctor told me you have GERD, and they gave me some treatment for that. It worked well for some time. And then they told me you had to do a camera test. I did it, and suddenly they called me to the clinic and they said, well, we have something, growth in your lower esophagus encroaching into my stomach. And they took a biopsy from this and he told me you had cancer. And if I remember correctly, the doctor said something about a Siewert 3 or something like that, which I don't understand very well. And they did for me a CT scan. I just want to know what's going on.
Sure, Mr. Salim, I do completely understand your frustration. But also, I think they had another camera test called an EUS, if you remember, and it showed that the tumor was at a very early stage. We called it a T2, and there were no lymph nodes involvement as well.
Yes, I think I forgot to mention that.
Sure. No worries. I think despite of the fact that there is a cancer of your esophagus, the good news is that it is still at a very early stage, and we can do lots of things about it. Well, in fact, I'm going to give you another bit of good news, which is the CT scan. CT scan didn't show any evidence of spread anywhere else.
Well, that sounds good. So what exactly are we going to do now?
Tumor type should be assessed in all patients with adenocarcinoma involving the gastroesophageal junction. Type 1, which is an adenocarcinoma of the lower esophagus with the epicenter located within 1 to 5 centimeters above the anatomical GOJ. Type 2, which is a true carcinoma of the cardia of the GOJ with the tumor epicenter within 1 centimeter above and 2 centimeters below the GOJ. And type 3, which is subcardiac carcinoma with the tumor epicenter between 2 centimeters and 5 centimeters below the GOJ, which infiltrates the GOJ and lower esophagus from below. So type 1 and type 2 tumors are normally treated in the same way as esophageal cancer. So type 3 lesions are considered gastric cancers and thus should be treated as described for gastric cancers. For a patient with a leukoregional gastric cancer, that is a clinical T2 or higher with any N staging, there is an evidence to offer perioperative chemotherapy. The preferred regimen is the FLOT, which is 5-FU plus oxaliplatin and docetaxel, but also FOLFOX and 5-FU cisplatin are other recommended regimens.
This is acting for clinical education, like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.